Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Today, we're taking a deep dive into one of the most severe and, frankly, terrifying adverse drug reactions out there, Stevens-Johnson syndrome, or SJS. This is a condition where the body's own immune system gets a signal horribly wrong and launches an all-out, catastrophic attack on the skin.
So just imagine this for a second. You take a really common medication, maybe an antibiotic or something for seizures, expecting it to make you better. But instead, your body turns on itself. So how in the world does a cure become a catastrophe? That's the mystery we're going to unpack right now.
All right, so let's set the scene. Our story almost always begins with something that seems completely routine. A patient starts taking a new medication, and at first, everything seems perfectly fine.
Now, what's so wild about this is the timing. See, SJS isn't like a peanut allergy where the reaction is immediate. No, this is what's called a delayed hypersensitivity reaction. The immune system kind of takes its time. It can be 1 to 3 weeks before it mounts its attack. The first symptoms are super vague, a fever, a sore throat, so it's incredibly hard to connect that back to a pill you might have started taking weeks ago.
So once that rash finally appears and starts to spread, that's when the real investigation has to begin. What on earth is happening at the microscopic level to cause such a devastating full-body response? Well, scientists have a couple of leading theories about how the immune system gets the wrong signal. The classic idea is the hapten model, where the drug latches on to one of our own proteins, creating this new thing that the body suddenly sees as a foreign invader. But there's a newer idea, the PI concept, that's even more direct. It suggests the drug molecule itself can just plug right into an immune T cell and flip the on switch, no middleman needed.
And once those T cells are activated, things get really bad, really fast. Think of them like the body's security guards gone rogue. They swarm into the skin and unleash this chemical weapon called granulysin. And granulysin has one job. It tells the skin cells, the keratinocytes, to die. This causes the top layer of skin, the epidermis, to literally separate and peel away from the body.
So you see this word here, apoptosis. This is the absolute key to the whole thing. The skin isn't just getting inflamed or damaged, it's receiving an explicit command from its own immune system to self-destruct. It's a programmed cell death.
Okay, so now that we know how the attack is happening, the next step for doctors is to figure out the scale of the damage. And this is critical because it helps them classify just how severe the situation really is.
You'll hear about SJS and another condition, toxic epidermal necrolysis, or TEN. They really exist on a spectrum, and the only thing that separates them is the percentage of the body where the skin is detaching. If it's less than 10%, it's SJS. If it's over 30%, it's full-blown TEN. And that area right in the middle, that's what we call the overlap.
It's also a bit of a detective story for doctors because they have to rule out other serious drug reactions like one called DRESS. And as you can see, there are some key clues they look for. DRESS usually shows up later. You see a specific kind of white blood cell in the lab work, and it's known for attacking internal organs. SJS/TEN, on the other hand, is notorious for its brutal attack on mucous membranes, so the eyes, the mouth, the throat.
So once that diagnosis is confirmed, everything shifts. The clock is ticking. It becomes this intense race against time, and every intervention is focused on one thing and one thing only: survival.
This is it. The single most important thing you can do. Identify the drug that's causing the problem and stop it. Immediately. For medications that clear out of the body quickly, this one step has been shown to directly reduce the mortality risk. You have to stop fueling the fire.
From that point on, you're essentially treating a severe burn victim. Patients are often rushed to a burn unit or an ICU. The whole focus is on supportive care.
managing fluids, fighting off infection with specialized wound care, getting enough nutrition into them, and of course, managing the incredible amount of pain.
But what if you could actually stop the immune attack itself? Well, that's where a drug called cyclosporin comes into the picture. It's a powerful immunosuppressant that goes right to the source and inhibits those rogue T cells, basically cutting off that self-destruct command.
Now take a look at this number, 43%. Just on its own, what could that possibly mean?
Well, it represents hope. A really important study found that patients with SJS/10 who were treated with cyclosporin had 43% fewer deaths compared to those who got another common therapy. Now, research is always ongoing, but this really highlights just how promising cyclosporin can be in these life-or-death situations.
All right, so we've looked at the crime, the investigation, and the emergency response. Now, let's profile the usual suspects, the drugs that are most often behind SJS and TEN.
This list here is kind of a most wanted list. You can see certain types of antibiotics, anti-seizure meds, and even allopurinol, which is a really common gout medication. But, and this is so important to remember, while these are the big ones, dozens and dozens of different drugs have been linked to SJS.
So, this brings us to the final and maybe the most fascinating piece of the whole puzzle. Millions of people take these drugs every day and are totally fine. So why does this horrible reaction happen to just a few people? Well, it turns out the answer is written in our DNA.
Yeah, so scientists have found these specific genes called HLA alleles. You can think of them as genetic flags that are unique to each of us. And for some people, a very specific drug paired with a very specific HLA flag triggers the whole immune catastrophe. So for example, if you carry the HLA-B5801 gene, you are at an extremely high risk for a reaction to allopurinol. Our own genetic code is a massive risk factor.
And that just leaves us with this huge, hopeful question for the future. As we get better at understanding these genetic links, we are moving into a new world of medicine, one where we can tailor drugs to a person's individual genetic code. It is totally possible that one day, a simple, routine genetic test before a doctor even writes a prescription could stop this catastrophe from ever happening again.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.